Bismillahirrahmanirrahim. Welcome to my channel, Doctor's Goal. Let's talk about multiple myeloma. What is multiple myeloma? Multiple myeloma is a type of blood cancer that develops from plasma cells in a bone marrow. Remember, students, normally when bacteria or viruses enter the body, some of the base cells will change into plasma cells. The plasma cells make antibodies to fight against bacteria and viruses to stop infections and diseases. Causes and risk factors. Causes of multiple myeloma are unknown, but some other risk factors include monoclonal gammopathy of undetermined significance, being exposed to radiation, some other chemicals, viruses are increased. The risk of multiple myeloma occur in older age. Peak incidence is 70 years. Pathophysiology of multiple myeloma. We have two types of bone marrow, red and yellow. Red bone marrow contains stem cells. Stem cells further differentiated to myeloid stem cell and lymphoid stem cell. Myeloid stem cell further differentiate into myeloblast, RBC, mast cell and platelets. Lymphoid stem cell further differentiate into lymphoblast. Lymphoblast further differentiate into B lymphocyte and T lymphocyte. B lymphocyte further differentiate into plasma cells, and plasma cell further produced antibodies. Plasma cells formed antibodies include IgG. IgG is the most abundant antibodies in serum and in extracellular fluid. IgA is found in mucosal membrane, mainly in the respiratory and digestive tract, as well as present in breast milk, tears, and saliva. IgM is the largest antibodies, mainly found in blood and lymph fluid. IgE predominantly found in tissue, primarily attached to effector cells such as mast cells and basophils, and increase in allergic reaction. IgD is found on the surface of B lymphocytes and also found in small amount in blood. To remember, immunoglobulin has a mnemonic GAM. Antibody structures. Antibodies typically consist of two heavy chains and two light chains. There are 5 kinds of heavy chain term: IgG, IgA, IgM, IgD, and IgE. Here you see light chain. Between two heavy chain present bond called disulfide bond. Light chain may be kappa or lambda. IgG kappa, IgG lambda, IgA kappa, or IgA lambda. But in multiple myeloma, mostly present IgG kappa. In multiple myeloma, light chain pass in urine called Bence-Jones protein. In multiple myeloma, B lymphocytes overproliferate into myeloma cells or cancerous plasma cells, which produced monoclonal antibodies, typically infective IgG and IgA. Only light chain produced by myeloma cells. Clinical presentation of multiple myeloma: bone pain mostly in ribs and vertebral column, pathological fractures due to lytic lesion. So, why fractures occur in multiple myeloma? It's due to increased osteoclast activity and decreased osteoblast activity. Before going to detail, we should know about osteoclast and osteoblast. So remember, osteoblast, these are bone forming cells. In osteoclast, these cells degrade bone. In normal condition, we have osteoblast and osteoclast. Rank receptor present on osteoblast and rank receptor present on osteoclast. When rank receptor interaction occur, it increase the activity of osteoclast. Activated osteoclast degrade bone for remodeling in normal condition. Osteoprotegerin OPG release from osteoblast and inhibit rank interaction and prevent over degradation of bone by osteoclast. Pathophysiology of multiple myeloma. Myeloma cells inhibit OPG, interact with bone mesenchymal stem cell and produce trans cells. Trans act on osteoclast progenitor cells and differentiate into osteoclast and increase activity of osteoclast. DKK1 release from myeloma cell act on osteoblast and decrease activity of osteoblast. The Rankel receptor express on bone marrow mesenchymal stem cell and interact with osteoclast progenitor and differentiate into osteoclast and increase the activity of osteoclast. MIP1 alpha directly release from myeloma cells and attach with osteoclast and increase the activity of osteoclast. Interleukin 6, it attaches to osteoclast. It has positive effect on osteoclast. After that, it goes and gets attached to myeloma cell and decrease apoptosis in myeloma cells. Lytic lesion. Lytic lesion, because of increased activity of osteoclast, lead to lytic lesion and after that lead to bone fracture. Hypercalcemia. The reason is that osteoclast dissolve the bone and release calcium into the blood and increase the calcium level in blood. Increased calcium level in blood lead to formation of renal stones. Some other symptoms include feeling tired or fatigued or confused, muscle weakness, nausea or vomiting, polyuria, polydipsia, and dehydration. Patient have risk of infection. The reason is that it's because of IgG and IgA produced by myeloma cell and monoclonal, thus making them ineffective. Anemia. The reason is that it's due to proliferation of myeloma cells in bone cavity and interfere with other cells production including RBCs, and is due to decreased erythropoietin production because of impairment of renal function. Renal insufficiency. Renal insufficiency due to accumulation of light chain, which is Bence-Jones protein in kidney, lead to kidney failure. Diagnosis of multiple myeloma. Best initial test is serum protein electrophoresis, IgG or IgA monoclonal spikes. In normal individual, gamma protein normal in urine electrophoresis. In multiple myeloma, M spike present. In multiple myeloma, patient electrophoresis show M spike. Immunofixation. To confirm which type of immunoglobulin cause multiple myeloma, we do immunofixation test. In given picture, show IgG lambda monoclonal protein identify in immunofixation. What happens when we do urine electrophoresis? Here is a normal individual urine. In multiple myeloma, a light chain spike present. These light chain also called Bence-Jones protein. Best test to confirm multiple myeloma, bone marrow biopsy. Bone marrow biopsy show plasma cells having greater than 10% CD138 positive. In normal individual, bone marrow biopsy show 2 to 3% plasma cells out of 100 cells. In multiple myeloma, patient bone marrow biopsy show greater than 10% plasma cells out of 100 bone marrow cells. CBC with peripheral smear. Peripheral smear show RBCs, Rulix formation, decrease hemoglobin. In 2/3 multiple myeloma patient develop anemia. Treatment of multiple myeloma. Treatment of multiple myeloma include chemotherapy, targeted therapy, bisphosphonates, and steroids. We start treatment in multiple myeloma according to age of the patient. If patient age is less than 70 years, we'll do chemotherapy, autologous bone marrow transplant. If patient age greater than 70 years, we'll give melphalan and prednisone. Chemotherapy. It kills fast-growing cancer cells. Drugs include melphalan and cyclophosphamide. Mechanism of action of alkylating payload. Alkylating payload with peptide carrier cross the cell membrane because it's lipophilic in nature. Aminopeptidase enzyme in the cell detach alkylating payload from peptide carrier. Since alkylating payload became hydrophilic in nature, so it gets accumulated in the cell, then it enters the nucleus through diffusion and cause the breakdown of DNA that lead to cell death. Bisphasphonates. Bisphasphonates decrease the activity of osteoclast cells by inhibiting FDPS enzymes. Drugs include pamidronate, zoledronic acid, and chlordronate. Mechanism of action of bisphosphonate. Bisphosphonate attach on hydroxypeptide binding site and release bisphosphonate component. Bisphosphonate inhibit the attachment of osteoclast to bone and osteoclast is fragmented by bisphosphonate. Normally, what happens to osteoclast? Normally, HMG coenzyme convert into mevalonate convert into grenyl pyrophosphate, and grenyl pyrophosphate convert into farnesyl pyrophosphate with the help of enzyme FDPS, and then it convert into prenylation of small GTPase and become a healthy cells, increase cell survival, form ruffled border and action ring, increase bone resorption. So when bisphosphonate inhibit FDPS enzyme, prenylation of small GTPs will not take place and cause disruption of ruffled border, and it may lead to inhibit the attachment of osteoclast to bone. Accumulation of bisphosphonate in osteoclast induce apoptosis in osteoclast. Bisphosphonate also give positive effect to osteoblast and release OPG. OPG decrease wrinkle ring interaction and decrease osteoclast activity. That is how bisphosphonate work and decrease bone resorption in multiple myeloma. Target therapy, in which we target specific genes and proteins that help multiple myeloma cells survive and growth. Proteasome inhibitors used to kill myeloma cells by inhibiting 26 proteasome. Proteasome inhibitors used in multiple myeloma is bortezomib. Mechanism of action of bortezomib. Bortezomib enter to the cell and attach to 26 proteasome that lead to increase the activity of J and K and release reactive oxygen species. These species act on mitochondria and lead to breakdown of mitochondria. You see mitochondrial breakdown occur. It also affect on ubiquitin protein p53, increase the activity of ubiquitin and lead to misfolded protein. As well as it also affect on NFKB, decrease the NFKB, decrease cell proliferation, decrease cell survival. And all these misfolded protein cell proliferation, decrease cell survival, and mitochondrial breakdown may lead to increased apoptosis and at the end cell death occur. Thanks for watching. If you like my videos, please subscribe my channel and press the bell icon.